Well, thanks very much, Tad, for those kind remarks. And this topic is one the program committee asked me to do. It's one I get asked about a lot and really don't talk about that much, but I'm going to do that today. And orthopedic innovation is important, innovation in medicine, because we make things better that way, but it is kind of a two-edged sword. It requires cooperation between doctors and industry, which can be good, but it also raises the potential for conflicts of interest and unethical behavior at times. These are my disclosures. I've worked with Smith & Nephew mostly, and Stryker a little bit, as well as some of the other companies. When innovation occurs, it's basically trying things out and seeing what works. So despite all the preclinical testing of new ideas in the lab or in small trials, ultimately these have to be used, and the good things stick and the bad stuff we try to forget about. So if you look at the Charnley hip replacement here, this goes back to 1969. Sir John Charnley, he was knighted by the Queen, cemented these things in a polyethylene cup, 22 millimeter head, and a cemented stainless steel stem, which dramatically changed the treatment for arthritis. That would never get FDA approved today, but back then you could just do stuff like that. And then after they were in for a while, some of them broke, and that led to cobalt chrome and titanium, which were these super alloys, also porous coated to get fixation. The other approach was to get rid of the stem and do a surface replacement, and those didn't work. Then after the porous coating, we had polyethylene wear problems because they stopped loosening, but the things would wear out and create osteolysis. So the solutions there were to get rid of the polyethylene, use metal on metal or ceramic on ceramic, which didn't work so well, and cross-linked polyethylene, which is what we've got. So if you kind of look at this, there's a gradual upward trend going over time from left to right. And so good innovations stick, problems are the ones we try to solve, and bad things that didn't work out, we, kind of ignore. So this predated the Charnley hip with metal on metal, large heads. Loosening and stem fracture I talked about led to the superalloys. Cement loosening became a problem, and then we got porous coating. Pre-coating was a way to get the cement to stick to the stem, and that didn't work out so well. And the solutions to wear, which is this problem, osteolysis, were multiple attempts to make the polyethylene or the counterface better, all of which looked good in the lab and didn't work in people. So there was a sharp contrast between the preclinical testing and what actually happens. And the polyethylene we found was sterilized in air, which degraded it, and so that led to getting rid of that and using non-sterilized polyethylene, but we still had this issue with the young active patient. What do you do with them? And they've got many years ahead of them. And so prior to even figuring out how well that non-gamma and air sterilized polyethylene was going to work, cross-linked polyethylene was used and the hard-on-hard bearings, and once again, trial and error, the cross-linked polyethylene kind of won. But you see this sort of gradual upward trend, and it's not only in orthopedics. This is something that's been repeatedly observed over and over in every technology, cars, computers, you name it. There's this sort of trajectory here, which is called the Custer demand for new technology, and then an incremental kind of increase here over time. This gap is if technology drives the need for improvement. So in other words, technology might cost more money, but it raises the bar. So the question comes, is it worth the cost of that new technology to get some improvement in clinical outcomes? Disruptive innovations are down here, and these are not always characterized appropriately in my mind, but disruptive innovations are things that cost less money, but they result in an improvement. So everybody would want that, right? So what is a disruptive innovation? Well, this is one that Kevin Bozick quotes sometimes, and it's a surgical procedure that was developed by a surgeon in South America as an alternative to transplant for cardiomyopathy, where the heart is just a big, floppy kind of organ, and they couldn't really afford the transplants down there, so he just cut out a little piece of the heart and sewed it back up and made it smaller. And it worked. So it was a disruptive technology that was an inexpensive alternative to the expensive transplant surgery. Well, disruptive technologies are cited quite a bit in healthcare in this study. The most disruptive innovations are omics, which I've kind of put down here because I didn't know exactly what they were. And you can see mobile health applications, telemedicine, a lot of things that we use now that have improved the quality of healthcare. They're, in my mind, not necessarily disruptive because they may cost more money. And so I would characterize some of these as more game changers. So a game changer is something that everybody looks at and says, wow, that's a great idea, and you almost don't care what it costs, whereas the disruptive ones cost less and still result in the same significant improvement in what we do, and that's where I think the misnomer comes up. Disruptive innovations are game changers. They're almost called the same thing to some extent, but in order for them to be successful, it really comes down to three things. Is it going to improve clinical outcomes? Is it going to lower cost? And is it going to improve efficiency? And you see this with all the ASC stuff, how efficiency is driving the need for better improvements in what we do there. Well, where do ideas come from? Okay, you have a right and a left side of your brain. The right side is the creative part, and you know people who can do this, the musicians, the artists, the creative people. The analytical side is more the nuts and bolts, the math science on the other half of your brain. But ideas probably come when the two sides of your brain find a way to talk to each other. And it's not something you can really force. It's something that's been written about a lot, and these are some of the many examples that are out there in history. You know, when the apple fell on Newton's head and he discovered gravity, how did that happen? Is this story true? Nobody really knows. Did Einstein dream about horses racing across the sky to figure out relativity? And how was benzene discovered from an idea about a snake seizing its tail? Well, maybe, maybe not. Nobody really knows. I mean, these are things that occur in the subconscious mind, but the aha moment has been written about innovation or invention in many books that describe a very similar occurrence when the two sides of your brain kind of talk to each other, and it's usually a subconscious occurrence. These are all books on invention. So in order to invent something, you have to have a problem you're trying to fix, and the problem has to be rattling around in your head somewhere. So for orthopedic surgeons, what do we think about? We think about, you know, what keeps you awake at night is something bad that happened to one of your patients, and you ask yourself, what could I have done differently? How can I prevent this from happening again? And so that problem is sort of rattling around in the left side of your brain. This is changing topics a little bit, but going back to this old argument, which has resurfaced in the 1980s, the issue in knee replacement was whether to align it anatomically or mechanically. Same thing that has come now with kinematic alignment, but mechanical alignment is a straight leg and a bone cut and prosthesis that's perpendicular to that, whereas anatomic alignment is the anatomic joint line in 3 degrees of Veris, but you still have a relatively straight leg. So mechanical alignment means that we make the bone cuts perpendicular to the mechanical axis. You can see the joint line there anatomically is in a little varus, and we're going to replace it with a knee that is parallel with these cuts and make a flat cut on the top of the tibia. Anatomic alignment is in 3 degrees of Veris, so the bone cuts are parallel with the joint line, and this part is tilted inward a little bit. So it requires putting the tibia in 3 degrees of varus. And that's kind of 2 schools of thought when I was in residency and training that were how to do a knee replacement with the PCA prosthesis or the IB prosthesis in mechanical alignment. Well, the problem with varus tibias is, according to the literature, they don't work that well all the time, particularly in heavy patients, because varus leads to loosening. So the one outcome that was considered most important in a knee replacement is survivorship. The nice thing about survivorship is you can see the wisdom of doing these kind of studies because they make us look good. You have one outcome, which is whether the knee replacement is still in the body. It might be infected, it might be loose, but it hasn't been revised, so that's a success. And here you can look at durability, and durability is important because, you know, patients don't want to go through this operation again, but they do want their knee to function well, and that becomes more of a driving force now. And mechanically aligned knees had better survivorship than anatomically aligned knees, so these won. So then the question is, okay, you make this mechanically aligned tibial cut, perpendicular mechanical axis. Well, now what do you do on the femur? Because you've got this gap laterally that's bigger than the medial gap. Okay, so the way to deal with that is to externally rotate the femoral bone cuts. So you remove more bone from the posteromedial than the posterolateral femur shown on the right. The yellow lines would be the AP cutting block. Well, you know, this works just fine, and you get a symmetric gap, and here you can see the joint line is now perpendicular to the mechanical axis. But back then, we didn't have a lot of sizes, and so you were always kind of in between sizes, and you could put the big one on, but it was too big. And if you put the small one on, it could notch over here. And so going back to this period of time, I'm at one of these meetings listening to, you know, the professors talk about how you have to externally rotate, and then the next guy gets up and shows how you fix these supracondylar fractures because you get a notch. And the notch occurs because, you know, you put on the small size and it notched in there and led to a fracture, so now you have to fix the fracture. As clinicians, I think we have a responsibility to question conventional wisdom. So you listen to these 2 talks, well, okay, you know, should I just go out and do that or think about it some more? And this is the basis of all the research and to a large extent the innovation that we do. So now I'm going to take you back in time to what I'd call the good old days. And the good old days was when I was in my practice, 2 years in my practice, so this is in 1991, probably before some people here were born. It was before we had cell phones. It was before we had the internet, okay? So just kind of swallow that for a little bit. And I'm at one of these meetings, which is sponsored by a company. So a company would fly you out to a nice place like Beaver Creek or Aspen, put you up in a nice hotel that you couldn't afford any other way, pay for your wife to go, and you're in this amazing ski resort place. You go to these meetings from 7 to 8 in the morning, and then you go ski all day. So, so I'm out there skiing, and I remember this. This is kind of how it started for me. And I'm looking at this, you know, talk of the distal femur and the external rotation, and then I'm riding up a chairlift, and I'm, you know, just kind of looking at the chairlift, and the chairlift sort of rocks back and forth as the wind blows it this way and that, and then I came down at the end of the day, and I kind of made this picture. So I said, well, how about if the bottom of the chairlift was this way, sort of tilted or rotated, and the top part was there, and you just filled this in with metal. And made that drawing. Had no clue how this worked, but I gave it to one of the company people, and this is what it turned into. And then the next thing I knew was one of the engineers from Smith & Nephew sends me this drawing, which is a drawing for a patent, and they went ahead and patented it and said, you know, we'll pay you royalties and all this other kind of stuff. And I'm like, okay, great. And that's sort of how it was done back then. So patents, which I didn't really know about until this happened, are not that complex. There's basically two categories. There's device patents, which patent the apparatus, the thing, and there's utility patents, which sort of patent a method, which is how you use it. And the device patents are stronger, but these are how they come. There's other problems that, you know, don't really exist now, but did back then. This is another example. I want to just take you through a few of these. And not all of them I can say I remember exactly, you know, kind of like what happened on the chairlift, but I do think that's the thought process that occurred. And when we had polyethylene wear, one of the issues was putting screws in the cup because, you know, it was thought that the metal would fret between the screw head and the screw hole, and so you wanted to use a cup without screws. So you ream a round hole and you put in a round cup, and this kind of thing would happen. It could sort of spin out if it wasn't in tight enough. And a couple solutions that were offered were to make the cup more elliptical or egg-shaped, and there were a few of these. And I remember one of the people from a company asked me, he said, you know, the other companies have these sort of non-hemispherical cups. It'd be nice if we had one, but we can't figure out how to get around the patents. And I had never seen the patents. These are the two of those patents that exist, and I kind of knew what they were. And now taking back to my own personal life, what happened for me when I had young kids, my job in the morning was to feed them and then get them ready for skiing, basically, which, looking back on it, was, you know, a really hectic kind of time, but I miss those times now, so I understand the value it had for me at the time, those moments with your kid. And one of the things I would do is cut an orange. So this is something I did every day, never thought about it. And anyway, when I got contacted about this cup issue, I woke up the next morning and I made a picture of orange that was cut and just kind of fell apart like that. And sure enough, the next thing, they send this drawing back with all these radiuses and stuff and said it gets around the patents. And I never even seen the other patents, but it shows you just what innovation is, and these devices are usually all about shapes and stuff. So when I look at patents, there's three parts to a patent. One is the abstract, which is a general description of what the patent is, what the problem is. Then there's a detailed description of what it is in kind of legal terms, and that includes a bunch of pictures. And then the last part is the legal claims, which is your novel ownership. So for me, when I looked at these things, I only looked at one part, which is the pictures. You should be able to look at a picture of a patent and understand what it is, and not have to read anything. But when we think, when we dream in images. And this is where these solutions can come from. This is a revision problem. When we revise a cup, we take out the old cup and we put in a bigger cup. So the bigger cup is non-physiologically sized. It's a little bigger than the normal acetabulum. So it means the middle of the cup here is a little higher than the middle of the anatomic acetabulum, and this raises the joint line a little bit. So you can make up for it by using a longer femoral head, and that's how we keep the leg length equal. And it's not a lot, but it's a little bit. So when we do these jumbo cups, you also want to keep the posterior wall intact. The anterior wall is sort of optional. So if we're reaming for a larger cup, we just kind of like, you know, keep that posterior wall, and the anterior wall might not be there anymore, and that's sort of okay. But the other thing along the anterior wall is the psoas tendon. And psoas tendon has become a real thorn for us as joint surgeons because we don't really have good solutions to it and try to avoid it. So going back to the morning, and I can't say for sure this is what happened, but I, you know, had kids and I had to feed them. You know, I can't cook very many things, but I could make eggs. And my younger son had to have fried sunny side up eggs, and he wouldn't eat the yolk. So I'm looking at this, And over and over and over, every morning, I'm staring at this fried egg sort of situation. I can't help but think it would fit in and avoid this head elevation part. And in order to not have him eat the yellow part, I had to take the spatula and cut off this white thing. So I'm doing this over and over and over again, and one day I wake up and drew this thing, which I think is probably related. I don't know for sure, but I think that's what happened. And it became a patent. I showed it around to the companies, and Stryker went ahead and did it, and this thing exists and has been successful. So intellectual property means there's a novel idea. If it hasn't been done before, it's patentable. Intellectual property can also be non-patentable. Know-how is intellectual property that you contribute to, usually the design of something, but patents are, very specific and unique. Not all intellectual property means it's a patent. It can be know-how, which is considered intellectual property. And so here you are, you have a great idea. And if your idea is in the right place at the right time, like some of the ones I've just showed you, you're pretty lucky. So there is a significant element of luck involved here, because you really never know what the right time is. If it's in the right place and the wrong time, well, that's a dilemma. And if it's in the wrong place at the wrong time, you got to sort of accept defeat and start over again. So if you have a patent and nobody wants it, then you could keep working on it, hope someone will get it, or develop it some more. And there's many ways to do this. You could make a prototype, do mechanical testing, or start a company, which is going to require some money, some risk, and keep moving it along with the hopes that your company is successful or a big company will buy the little company. Orthopedic innovation historically has been driven by the implant manufacturers to get a design team if they want something. They need, okay, that company has this thing, we need one too. And so they have a portfolio, they want to fill their thing. Then they'll assemble a design team of surgeons and engineers. This usually results in incremental improvement. It's a safe way for the companies to go. It's a good thing because it gets new improvements generally in what we've done before, whereas the individual idea, the light bulb, I see this as the way you produce major innovation, not so much in a team approach, but it can be a contribution to the team. Now, a couple other things you need to know about. And one of them is the federal anti-kickback statute, which is shown here. It prohibits any company, pharmaceutical or medical device company, from paying any doctor in exchange for referral of goods. And you can see how this is a dilemma. If you're a doctor working with a company and you're prescribing an implant or a pharmaceutical drug to be used in the hospital buys it. It's not your money that's buying it. It's not the patient's money that's buying it, but you're directing the hospital to buy it. And if you have a relationship with that company, that's an inherent conflict of interest, which is where this comes. It also applies to referring patients to your own MRI and PT and stuff like that. There are safe harbors for those situations, and also this prohibits a doctor from receiving royalties, a percent of sales of products, unless they have intellectual property. Well, the good old days came to an abrupt end in 2008, and this is what happened, which has been published in the orthopedic literature here in JBJS. This was the DOJ, Department of Justice investigation of orthopedic surgeons. Chris Christie was the DA for the state of New Jersey. He was trying to become governor at the time, and he alleged these, this is quoted from the JBJS article by Bill Healy, that all these things we got in the good old days, trips to luxury resorts for CME meetings, meals, inappropriate gifts, and payments to opinion leaders were done in exchange for using or prescribing those specific implants. And here he is. This was the announcement. 5 companies that accounted for 95% of the market in hip and knee replacements avoided prosecution by settling with the DOJ, which is sort of a money-making branch of government. And although I find Chris Christie personally, repulsive in every way, you gotta admire his ingenuity, because this is what he did. Here's the amount of money that was paid to each of these companies, $311 million. But beyond that, his 5 buddies shown here were monitors. And so they monitored the companies for 18 months and received some undisclosed amount of money to do that, which was paid to them by the company. So this money went to the US government. The rest of it didn't go to Uncle Sam. It went to these 5 people that no doubt wound up in Chris Christie's reelection fund, and he became governor. You may notice that Stryker had no settlement, and probably just a coincidence, but Stryker is located in Mahwah, New Jersey, where 16,000 employees who are probably registered voters in New Jersey didn't lose their jobs because Stryker didn't have to pay a settlement and they didn't get laid off. So this is where the brilliance is. But in any event, I don't want to digress too much of that. There were, there is good and bad outcomes of this. Things had gone too far the other way before the DOJ. And before the DOJ, surgeon consulting and development contracts, so development meaning, design team stuff, were merged together typically. The companies were teaching CME courses and promoting academics with an industry tilt. So, those things you can't really argue were not good. You can't really argue that they were good. They were not. And manufacturers of total joints developed new products internally, which is different than the car industry, the computer industry, where they just wait for a little company to discover something and then buy it. After the DOJ, which is now, there's a clear separation of surgeon consulting and development contracts. The implant company medical education is really restricted to teaching how to use their products. So they're mostly cadaver courses, and they're not teaching academic things. Manufacturers of total joints really stopped doing things internally, and I think this is what happens with regulation. Regulation is good because it stops sleazy and unethical behavior, but it makes it harder for everybody else who is doing it the right way to get things done. So the companies basically stopped making new hip and knee replacements, and they have shifted to better technology to put in the joint replacements, navigation, robotics, virtual reality. Now, another thing that is important to know about is the Sunshine Act, which had nothing to do with the DOJ investigation. This was a law that was supported, bipartisan, widely accepted, and requires manufacturers of drugs and medical devices to report payments of value given to physicians and teaching hospitals. It includes research, consulting, royalties, meals, travel to meetings, all that kind of thing that you should be familiar with. Well, what is the accuracy of reporting this stuff? There have been a couple studies of this, and this may surprise you, but in this one, the authors compared the disclosures of publications in orthopedic and general trauma literature with what's on the Sunshine Act website. And they found 490 authors accurately disclosed their relationship with industry 16.6% of the time, which is nothing to brag about. And you might say, well, that's horrible. These guys were all just lying. But maybe not. I mean, what goes on this website is if you're at a CME meeting and some company is sponsoring lunch, and as you're walking in to grab your lunch, they scan your tag, that $15 thing shows up on this website. So it may have been an oversight as much as anything else, but it shows what's out there. So what's out there and why, and who cares about it? After the Sunshine Act, if you query patients about what the doctors get for go into a meeting or get paid by industry, they really don't care. That's been shown in the literature. Hospitals do care, and they should, and this was the intent of it, because once again, if you have a relationship with a company and you're prescribing that product for the hospital to buy, you're spending their money on their thing, it's okay to do that as long as it costs the same as everything else. And employers care. So you ask yourself, well, why would my employer care? Well, this is why. Because who owns your ideas? You might think that whatever's in your head you own, but if you're an employee, which means if you go to work and you don't own the building you're working in, you're an employee, then depending on the situation, the employer, if it's related to your work, can claim your intellectual property is the employer's, unless you can prove the idea was personally not part of the work, it belongs to the company. So if you invent a work of art or song or something like that, but if it's related to healthcare, there may be an issue. There is an exception to this in California. An employer rights to an invention shall not apply if the employer developed it entirely on his or her own time with your own resources. That includes email, phone, computer, things like that, with a few exceptions, so it's sort of in the gray zone. So it's probably just a coincidence, but a lot of inventions seem to get invented in that 1 month in between jobs. And, there are ways to do this, to notarize an invention disclosure and just keep it somewhere, whether or not you patent it or not. And patenting is another option. Filing a provisional patent, which is sort of a placeholder for a year or so. So I would say at present, surgeon consultants teach implant company sponsored courses, and development opportunities for surgeons since the DOJ and this change are more with small companies and startups, and that's really where the opportunities are. I think that the future, this is my best guess, is that the large companies, 20 years from now, I think the hip and knee replacements are going to look the same as they do now, somewhat because there's not a lot of room for improvement, but also, why bother? It's just too cumbersome. The path for a company to make a new hip or knee replacement with the current regulations is probably 10 to 15 years, and it's just not worth it. They may do small additions to existing products, inserts, porous coating, more sizes, things like that. And I think what you see now is an explosion in new technology, robotics, virtual reality, navigation. So we've gone to better ways to putting these things in, improving the accuracy, which is also very important. But those things are likely going to be developed by small companies and then bought by the big ones. This may not apply to other specialties outside a hip or knee replacement, where they're still doing things internally and making improvements in the implants and that type of thing, but this is kind of how I see where we have been and where we are and where we're going with technology and joint replacement. And I'll stop there. Thank you for your time.